Thank you so much, Dr. Weinberg, for this wonderful presentation. And this was, it took us through the journey of multiple fetuses, and it gave us also a perfect segue to the next speaker presentation. So it's our honor, actually, to welcome Professor Igor Konstantinov. He is a professor of surgery and pediatrics at the University of Melbourne, and he's also the director of the Genomic and Regenerative Medicine Center in Melbourne. Welcome, Dr. Konstantinov.
My name is Igor Konstantinov, and my talk today will be based on the American Association for Thoracic Surgery 2024 expert consensus that I presented last year on behalf of the multidisciplinary expert group. We made a strong and moderate class of recommendations based on non-randomized, limited data, and expert opinion. Terminology. Circular shunt in neonates with Epstein anomaly results from pulmonary insufficiency causing the blood to flow from aorta to the pulmonary artery through PDA, then to the right ventricle through tricuspid valve, into the right atrium, ASD, into the left ventricle and back to aorta. It is important to emphasize that the fraction of the circular shunt can be different, thus creating a spectrum from hemodynamically stable patients to those in cardiogenic shock. Functional pulmonary atresia, on the other hand, occurs when there is no or minimal antegrade pulmonary flow and includes those with mild associated pulmonary insufficiency. We made recommendations for preoperative assessment of fetuses and neonates with Epstein anomaly, and I won't delve on it too much as this consensus has been published and easily available online. In unstable neonates, palliative comfort care may be reasonable in those with severe associated lesions. Those unstable with the circular shunt should have emergent interruption of the circular shunt. Those in cardiogenic shock or hemodynamic instability with low right ventricular systolic pressure should undergo Starnes operation. Currently, modified Starnes procedure to facilitate subsequent biventricular repair is preferred. Basically, intraluminal patching of the main pulmonary artery is performed not to disturb pulmonary artery, and the right ventricular inflow fenestrated patch is sutured to the tendon of Todaro to avoid damage to conduction system, leaving coronary sinus draining to the atrium or to the ventricle. The latter may facilitate right ventricular development. In stable neonates, medical trial of ductal closure is reasonable. Those with inadequate pulmonary blood flow may need a shunt. Importantly, subsequent procedures following Starnes procedure should include either single ventricular ablation or consideration for biventricular repair. Whenever possible, biventricular repair for symptomatic neonates with Epstein anomaly with or without Starnes procedure should be deferred until 3-4 months of age, when bidirectional cover pulmonary shunt can be added safely to unload the right ventricle. If biventricular repair is performed, not crack repair is preferred in neonatal period, as it is a simplified procedure and does not require detachment of fragile tricuspid valve leaflets. The silver repair is more anatomical, and it is preferred either for infants or older children. In not agreg repair, suture is placed to decrease the annulus size quite significantly, and if the valve needs to be replaced, it can be replaced. It is important to preserve native leaflets so that subsequently the prosthesis can be removed and repair can be done later on in life. The silver repair is a more elegant procedure and it is more anatomical. Basically, anterior and lateral leaflet is detached, and septal leaflet is reconstructed often with a pericardial patch, and the annulus is reduced. This is PR code to our published consensus, which is easily available online and can be read in detail. Now I talk about some controversial patients, difficult patients with Ebstein anomaly. Neonate with a circular shunt. This was 4-day-old child weighing 2.8 kilos with severe fetal hydrops, necrotizing enterocolitis, severe ascites. Grade Ormond Street echocardiographic score was 0.79, and right ventricular systolic function was very good, generating good pressure. Thus, biventricular repair was performed. And in this patient, there was a distinct lack of lateral leaflet, so it was reconstructed with a pericardium. The annulus was reduced, and a very large atrialized portion of the right ventricle and a portion of the right atrium was removed. And most importantly, this patient had severe pulmonary valve insufficiency due to rudimentary pulmonary valve, and it was replaced with a 12 millimeter valved conduit. So this patient was doing well at 2 years and now had a bidirectional cover pulmonary shunt. Another difficult patient, neonate with aortic atresia, double discordance, and Ebstein anomaly. 1-day-old weighing 3.6 kilograms. This patient had Norwood-Starnes operation shortly after birth, and then subsequently bidirectional cover pulmonary shunt at 3 months of age. Currently patient awaiting Fontaine with normal left ventricular function. A neonate with large ventricular septal defect and Ebstein anomaly. Very difficult to manage. So this patient had severe Ebstein anomaly, 2 kilograms, premature baby, and also very large anterior muscular VSD. Essentially, the patient had large left ventricle to right atrium shunt. So this is intraoperative view, and of course the question is what to do with this patient. Should the patient undergo Starnes procedure and pulmonary artery banding, or should VSD be closed and patient have Starnes procedure, or biventricular repair? And you see here a very large right atrium and large atrialized portion of the right ventricle, and this is a coronary artery, right coronary artery, and branches here, acute marginal branch and posterior descending, and a very large right atrium. The patient had low cardiac output, very severe ascites, and persistent supraventricular tachycardia with large left ventricle to right atrial shunt. So now the right atrium is opened and the tricuspid valve is exposed. The vent is placed through the ASD, which was reasonably large size. And cardioplegia is given while the valve is being exposed. Now again, it is not clear what to do in this patient's Starnes or biventricular repair. So I elected to do biventricular repair in this patient, and this is the only part of tricuspid valve which is anterior leaflet, and there was no septal or lateral leaflet whatsoever, and instead it was very large tricuspid valve annulus as expected. This is anterior leaflet, and first I examine it thoroughly to make sure that there are no fenestrations in the leaflet itself. And it is clear that the annulus must be reduced quite significantly in order to make this valve competent. And this is the rest of the annulus now, and atrialized portion of the right ventricle, which is very thin, and the coronary sinus is there. So an attempt is made to look at VSD from the tricuspid valve, but it was not possible to reach it. So now incision is made in the right ventricle, and you see left anterior descending coronary artery in between left ventricle and right ventricle. And you can appreciate the size of this right ventricle, which is very large. Yet contractility of the free wall of the right ventricular outflow tract and the rest of the right ventricle beyond the atrialized portion appeared to be very good. So now this incision is made here parallel to LAD to open the right ventricle so that the large ventricular septal can be exposed properly and closed. So and now the ventricular septal defect started to appear in view, and in a minute I will be able to show it to you properly. So this is a large ventricular septal defect which is anterior and in the muscular septum. Ventricular septal defect is closed with pledgeted 6-oprolene running suture and glutaraldehyde treated autologous pericardial patch. And this is a very good approach as it exposes the large ventricular septal defect very well and allows reliable closure. Now ventricular septal defect is closed and the incision in the right ventricle is closed with 6-oprolene double running suture. And this is quite a good and reliable closure. I put a little bit of TCL on top of it, but it doesn't bleed. Now, this is the largest Hegar dilator that we have in our disposal, size 27, and it goes easily through tricuspid valve in this 2 kilograms baby. The estimated size of tricuspid valve for 2 kilogram baby is about 10, 12, 14 millimeters. And I aim to reduce the annulus to 14 millimeters. Here I put a pledgeted stitch in the proximity of the coronary sinus. And this will be a central stitch that will divide this valve essentially in two parts. One which will be functional, and it will be closed by the anterior leaflet of the tricuspid valve. Here I go to the annulus here, next to where the anterior leaflet is attached, and the other part of the valve of the annulus will be closed with the same suture, and the tricuspid valve annulus will be decreased roughly half to ensure competence of tricuspid valve. This is size 14 Hegar dilator, which is placed through the functional orifice, and it will be held in place while the annulus of the tricuspid valve is reduced. Now the plagiated suture is tightened, and the same suture is used to facilitate those plagiates again, and then it will be used to close the remaining orifice, which will be non-functional orifice of the tricuspid annulus, and the tricuspid valve annulus will be reduced half. So this is, you see how much of the annulus needs to be plicated here, and this technique is rather effective in plicating atrialized portion of the right ventricle. As I close this orifice, the annulus is reduced, and the plication of atrialized portion of the right ventricle is achieved. And this is yet uncharted territory. It is not known what is to do with these patients with neonates in such poor condition with large ventricular septal defect. If Starnes operation and closure of VSD would be best, or Starnes operation without closure VSD and pulmonary artery banding could be performed, yet whatever procedure is done, the competence of tricuspid valve is important. Now this is a water test, and now the valve is very competent and holds the water very well. Atrial septal defect, you see it is reasonably large here. So now I use 5 millimeter, this is 5 millimeter Hegar dilator, to reduce the size of VSD, atrial septal defect, I'm sorry, to roughly 5 millimeter in diameter. And again, it would be important to make sure that this atrial septal defect is kept open. So if any concerns, it might be reasonable to put a Gore-Tex membrane with predetermined fenestration of a certain size, and usual reduction of the very large right atrium is performed. So following surgery, his persistent supraventricular tachycardia was not an issue anymore, and it was resolved immediately. Clearly it was driven by a very large left ventricle to right atrium shunt, and the patient required only 0.03 mics per kilo per minute of inotropes and had very good function. This is post-operative echocardiogram, demonstrates no tricuspid insufficiency, reasonably good right ventricular function, and good forward flow through the pulmonary artery. The patient was transferred to intensive care unit in a stable condition. Unfortunately, in a few weeks, patient had neurological complication and the care was withdrawn. So in conclusion, risk stratification is essential in neonates and infants with Epstein anomaly. Those patients are very difficult to manage early in life. Palliative comfort care may be reasonable in neonates with high-risk features. Unstable neonates with a circular shunt should have emergent interruption of the circular shunt and are commonly palliated with the Starnes procedure. Stable neonates should undergo ductal closure. Those with inadequate pulmonary flow may have ductal stenting or a systemic to pulmonary artery shunt. Finally, subsequent procedures following Starnes procedure should be a single ventricle palliation, but it is important to consider biventricular palliation. So conversion to biventricular repair should be considered in every patient before one would commit them to univentricular circulation. Thank you so much.
Thank you very much, Dr. Konstantinov. And I think Dr. Konstantinov will join us live from Melbourne for questions.
Hello, thank
Hi.
you for the opportunity to talk.
Good morning. How are you this morning?
Very well. It's
Excellent.
almost midnight.
Very good. I actually follow you on Twitter, and I learn a lot from the surgical papers you always publish, so I truly appreciate you sharing that. I have a question about the neonatal approach. Now, I know the group was a very large group of experts writing that paper. Is the approach always for the neonatal Epstein was with the Starnes procedure, or were there some surgeons who would prefer to do a neonatal tricuspid valve repair?
Well, yes, of course. Nothing is written in stone, most importantly. And as we all know, every adult with Epstein anomaly was once a neonate with Epstein anomaly. Not all of them require surgery at the first place. But then it would be very reasonable and preferable to do Starnes procedure, as it is reliable operation and most likely will give predictable outcome. And then it does not exclude biventricular repair, most importantly, and biventricular repair can be done later. A very difficult problem of a neonate with severe Epstein anomaly and large ventricular septal defect. What to do with them? You cannot just do Starnes procedure and hope that it will work. There will be still large VSD and it will not decompress the right ventricle. It is a problem. What do? You do Starnes and you don't close VSD, or you do Starnes and you close VSD. It's problematic. So, and of course, if you have good, strong ventricle, well, you may prefer to do biventricular repair right away, as I demonstrated in this video that I presented. But then in a small baby, 2 kilograms baby, tissues are fragile. You may not want to detach this valve and reattach it again using full-scale cone repair. Or, of course, another option is to put a prosthesis there and then come back later on to repair the valve, to do cone repair. But then you have to do something to ventricular septal defect or do pulmonary artery banding. And if you do Starnes and pulmonary artery banding, but leave VSD open, right ventricle will be very large and not decompress. So it's a big problem, and it's a work in progress. Most important, I think, is not to be dogmatic about anything at this stage.
Excellent. Thank you very much for explaining that. That was an excellent explanation. I have a follow-up question. Now, in newborns who are not critically sick to need Starnes, but they seem to need more pulmonary blood flow, is there a role for doing a shunt only or a PDA stent in this population? And would you prefer one approach over the other?
The answer is yes. I believe you have to do a shunt or a stent if there is not enough pulmonary flow. The answer is quite simple here. Shunt versus stent, it depends on what you do best in your institution. I cannot make recommendation here. If you can stent PDA safely in a small baby, by all means, it is a very good approach.
Mm-hmm. Excellent, excellent. And Dr. Konstantinov, you alluded to the cone after Starnes operation, like, later on conversion to biventricular repair or like 1.5 repair. Is that an approach that you also do in Australia?
Yes, and it is evolving approach, and the overall world experience is very limited. But this is what we now think the trend will be within the next few years, as cone repair has been proven to be very reliable procedure. And it is important to proceed to cone operation at about 3-4 months of age. Why is this 3 or 4 months of age? Well, of course, because the pulmonary resistance will drop, and then you have more options. You can add BCPC if you need to. And a very important thing for everyone to realize that Starnes procedure must not exclude subsequent biventricular repair.
That is excellent. Thank you so much, Dr. Konstantinov, and thank you for joining us live from Australia. For the sake of time, we will proceed to the next presentation, but I'm sure the audience will have a lot of questions online, so please answer them in the chat, and thank you so much. All right.
Thank you.